All right. This is Battle Tested Nursing's Real Talk with Nurse Mindy podcast. Okay. This is the historical series. Title for tonight is The Submissive Woman and the Orgasm. Unpacking a 1953 medical guide, guys. Come on. It's going to be a good one. Y'all. Okay. I need you to sit down for this one, okay? Actually, no. If you're driving, keep your hands on the wheel. If you're on the treadmill, hold on to the rails. Because what I'm about to read to you from a real published medical textbook from 1953 is going to make your jaw hit the floor. I'm talking about a so-called pictorial medical guide, a book that was sitting on nightstands and in doctors' offices that had some very strong opinions about women, sex, submission, and whose fault it was if a woman didn't have an orgasm. Spoiler alert. According to this book, it was basically always the woman's fault. She was either too submissive, not submissive enough, or just, and I'm going to quote here, innately incapable. Yeah, innately incapable. We're going there today, folks. We are going there today. Okay. Welcome back to Real Talk with Nurse Mindy, part of the Battle Tested Nursing family. I'm your host, Nurse Mindy, and this is our historical series where we crack open old medical textbooks, dust off the cobwebs, read what they actually published and recommended to real patients and real families. And then we hold it up to the light of the modern evidence-based medicine and say, what were they thinking? And sometimes we're surprised because we actually got something right. But today is not one of them days. Well, not entirely. There's a couple of little nuggets buried in there that we'll talk about, but mostly this is a masterclass in how cultural bias, patriarchal thinking, and a fundamental misunderstanding of female anatomy and physiology and psychology got dressed up in a white coat and called itself medicine. Now, before we dive in, let me get the important stuff out of the way, okay? All right, everybody, disclaimer time. And I know. Go ahead and say it, Mindy. We all know the drill, right, by now? Well, we do this every single episode because it matters. So here we go. First and foremost, I am a registered nurse. I am not your nurse. I am not your doctor. I am not your therapist. Nothing, and I mean nothing that I say on this podcast should be taken as personal medical advice, personal psychological advice, or a substitute for a conversation with your own licensed healthcare provider. If something we talk about today resonates with you or raises concerns about your own health, your own relationships, or your own sexual being, please reach out to a qualified professional, your OBGYN, your primary care provider, a licensed sex therapist, a licensed mental health counselor. Those are your people. I'm just here to educate, entertain, and occasionally lose my mind over these old textbooks. Second, today's episode deals with topics of a sexual nature. We are going to be talking about sex, orgasm, arousal, consent, or the lack of discussion of consent, and historical attitudes about women's roles in sexual relationships. This is an adult conversation. If you have little ears in the car or in the room, this might be a headphones episode. You've been warned. Okay. Third, we will be discussing historical medical text that reflects attitudes and language that many people will find offensive, outdated, and potentially triggering. The language in this 1953 text reflects deeply patriarchal. I don't know why I can't say it. patriarchal, heteronormative views. So it does not reflect the views of battle-tested nursing. It does not reflect my personal views, and it absolutely does not represent modern evidence-based medical practice. We are reading it to learn from it, to understand how far we've come, and to recognize that some of these attitudes, and let's be real, are still lurking in corners of our culture and even sometimes in healthcare settings today. Fourth, this podcast is for educational and entertainment purposes only. We are an evidence-based nursing community, and we take that seriously. When I reference modern research or clinical guidelines, I'll do my best to point you towards those resources. But again, this is a podcast, not a clinical visit. And finally, if anything in today's episodes brings up feelings related to sexual trauma, coercion, or abuse, please know that help is available. The National Sexual Assault Hotline is available 24/7 at 1-800-656-HOPE. That's 1-800-656-4673. Or you can chat online at RAIN with 2 N's, RAINN.org. You are not alone, and you deserve support. Okay, all the disclaimers are done. Let's take that deep breath, guys. Let's do it. Let's get into it. All right, so what I have in front of me is a passage from a 1953 pictorial medical guide. This was the kind of book that was marketed to everyday families. Think of it as the WebMD of the Eisenhower era, okay? Except it was a big hardcover book with illustrations, and it covered everything from first aid to apparently your sex life. And this particular section, it's a doozy. It's broken into 2 parts, but the first is literally titled, and I'm not making this up, The Submissive Woman. And the second part deals with orgasm. So I'm going to read the whole passage first, straight through, exactly as it was published. I want you to hear it in its entirety, in its original voice, and then we're going to go back through it piece by piece, okay? Ready? Here we go. All right. The submissive woman. Often women have strong feelings that it is desirable for the man alone to do all of the courting and preliminary caress and preparation. They feel that any approach on their part to their husbands is unsuitable and dangerous, a violation of an unspoken and unwritten rule of proper feminine behavior. This is a false assumption, supported by the social attitudes of the past and arising out of the complex background. More true is the fact that the ardent woman will be as anxious to caress as to be caressed, as eager to handle as to be handled, to fondle as to be fondled, and will wish to do her share to promote the gratification of her partner in the sexual act. However, some women feel that they have done their part if they have submitted. This is carrying the submissive role of the female to the destructive extent, and often indicates no real submission at all, but a defense of the woman against the unwished for sexual approach of their husband. Under such circumstances, it is more than likely that the supposedly acceptable part of the act itself will be a great disappointment to the woman. This disappointment comes from her inability to achieve the climax. And then we move into the section on orgasm. The orgasm or climax, the climatic release of tension in both partners to the sexual act, is its immediate goal. Ideally, orgasm should take place in both the man and the woman simultaneously. But this is not too frequently the case in a circumstance, which I think must be admitted at the start. The failure to accomplish it can be ascribed to various circumstances. Some of these have Just we have discussed in previous paragraphs, these have to do with the inability of the woman to really accept sexuality. Those women who fail to react with the expected response are termed frigid. Beyond the problems of women, there are certain failures in the man which may interfere with sexual climax in the woman. These failures arise from an exaggerated rapidity on the part of the man in the sexual act, and with achievement of orgasm altogether too early for the same accomplishment to be reached by the woman. For the woman to achieve orgasm, it is necessary that the man shall be able to maintain his erection a long enough time to allow the woman to reach the point of tension, which will permit her to experience orgasm. Many men are psychic incapable of that duration of erection. However, it must be said also that the equal number of women, and perhaps more, are innately incapable of orgasm independent of the accomplishment of the man. Wow. It is important to consider what the value of orgasm is and what the penalties for failure of orgasm may be to the woman's sexual life. Okay. Where do we even start with all of that? Actually, I know exactly where to start. We start with what I always think of in context is everything. So let's set the stage, okay? It's 1953. Dwight D. Eisenhower is president. The Korean War is finally winding down. I Love Lucy is one of the biggest shows on TV, and Lucille Ball and Desi Arnaz can't even be shown sleeping in the same bed on screen. Think about that. A married couple, real life and on the show, and the network wouldn't show them in a double bed. They had twin beds. Twin beds. That's the world this book was published in. Women had only had the right to vote for 33 years. The birth control pill wouldn't be approved by the FDA for another 7 years. And that wouldn't happen until 1960. Marital rape, not recognized as a crime in all 50 states until 1993. Let me say that again. 1993. Not 53, 93. I was alive. Many of you listening were alive. In 1953, a woman often couldn't open a bank account without her husband's permission. She couldn't get a credit card in her own name. That didn't change until 1974 with the Equal Credit Opportunity Act. In many states, a woman couldn't serve on a jury. The idea that a wife's body belonged to her husband was not some fringe belief. It was codified in law and in culture. And in medicine. Medicine was overwhelmingly practiced by men, researched by men, written by men for men. Women's health, and especially women's sexual health, was viewed almost entirely through a male lens. The female body was understood in a relation to what it could do for men, bear children, and provide sexual satisfaction. Sigmund Freud's theories were still enormously influential in 1953. And Freud, bless his deeply problematic heart, had declared that there were two types of female orgasm. The clitoral orgasm, which he considered immature and neurotic, and the vaginal orgasm, which he considered the only real mature, psychologically healthy orgasm. This theory, which has been thoroughly debunked, caused incalculable harm. It told generations of women that if they couldn't orgasm from penetration alone, something was psychologically wrong with them. They were immature. They were neurotic. They were, and here's that word from our text, frigid. So when we read this passage, we have to understand that it wasn't written in a vacuum. It was written in a culture that fundamentally did not see women as full sexual beings with their own autonomous desires, their own anatomy, and their own right to pleasure. And it was written by someone who, however well-intentioned they may have been, was swimming in that water. With that said, let's break this thing down, shall we? Okay. Back to the text. Let's start with the very first section, which they titled The Submissive Woman. The passage opens with, often women have strong feelings that it is desirable for the man alone to do all of the courting and preliminary caress and preparation. Now here's the thing. Is this observation wrong in 1953? No, honestly, it's probably pretty accurate. Women in the 1950s were socialized to be passive in sexual encounters. They were taught that good girls don't initiate. They were told that desire was something that happened to them, not something that they actively felt or pursued. So as a sociological observation, sure, that'll track. But notice the framing. It says women have strong feelings that this is desirable. It's placing the belief inside the woman as if it's her own personal hang-up rather than naming it as what it actually is. A product of systemic social conditioning. That's a subtle but really important distinction, because if it's her personal feeling, then it's her personal problem to overcome. But if it's a product of the entire culture she was raised in, the churches, the schools, the magazines, the movies, maybe her mother, grandmother, every authority figure she ever had, then maybe the fix isn't just telling her to loosen up. Maybe the fix is changing the culture. And we're still working on that, by the way. Still working on it in 2026. Now, the text continues. This is a false assumption supported by the social attitudes of the past and arising out of the complex background. Okay, I'll give them this one. Credit where credit is due. The author is acknowledging that this passivity is a false assumption rooted in social attitudes. That is, for 1953. A somewhat progressive statement, maybe. They're saying, ladies, you've been told a lie. Now, I have issues with how they follow up on that, and we'll get there. But the basic idea that women have been socially conditioned to suppress their sexuality, that's not wrong. That's actually kind of ahead of its time for a mainstream medical guide in the Eisenhower era. And then we get more true is the fact that the ardent woman will be as anxious to caress as to be caressed, as eager to handle as to be handled, to fondle as to be fondled, and will wish to do her share to promote the gratification of her partner in the sexual act. And here's where I start to get itchy, because on one hand, they're saying women have sexual desire and that's normal. Great. But look at the endpoint. What's the goal of the woman's active participation? To promote the gratification of her partner. Not her own gratification, not mutual pleasure, not connection, not her own orgasm, her partner's gratification. Even when this text is trying to be progressive and tell women it's okay to be sexual, the purpose of their sexuality is still defined in terms of what it does for the man. This woman is still in service. She's just been promoted from passive service to active service. And today, what does modern sex, therapy, modern psychology, modern medicine say? Modern evidence-based approaches emphasize mutual pleasure, individual autonomy, communication, and this is huge, the idea that each person is responsible for understanding and communicating their own needs. It's not about the woman serving the man or the man performing for the woman. It's about two or more. We're inclusive here. People engaging in a shared experience where everyone's pleasure matters equally. All right. The World Health Organization's definition of sexual health, updated over the years, emphasizes that sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. Notice what's centered here: pleasure, respect, autonomy, safety, not the gratification of your partner. Your well-being, your experience. Now, the second paragraph of this section, this is where it gets really interesting and really troubling. However, some women feel that they have done their part if they have submitted. Full stop. Hold up. Let's sit with that word. Submitted. Not participated, not consented, not engaged, submitted. Like a conquered territory. Like a dog rolling over. The language itself tells you everything about how this author and this culture viewed a woman's role in sex. She submits, the man acts, she receives. This is not a description of a mutual, loving sexual encounter. This is a description of a power dynamic. And the fact that it's presented in a medical textbook as the baseline, the default, and the norm from which the deviations are measured, that is deeply, deeply telling. Then the text says, this is carrying the submissive role of the female to a destructive extent and often indicates no real submission at all, but a defense of the woman against the unwished for sexual approach of their husband. Now, this is where I need everybody to lean in, because this sentence is doing something really complicated and really problematic. But there is buried under layers of 1953 paternalism, a kernel of something important. The author is observing that when a woman is completely passive and emotionally checked out during sex, it might not be because she's being a good submissive wife. It might be because she doesn't want to be having sex at all. The phrase unwished for sexual approach is doing a lot of heavy lifting there. In modern language, what the author is dancing around without ever actually naming it is the concept of coerced sex within marriage. Or, to use the term they couldn't or wouldn't use in 1953, marital rape. Remember what I said earlier. Marital rape was not recognized as a crime in all 50 states until 1993. In 1953, a husband had legal and social entitlement to his wife's body. If she didn't want sex and he did, her job was to submit. And this text is observing almost accidentally that the dynamic doesn't lead to satisfying sex. No kidding, you think? But instead of saying maybe we should examine whether this woman actually wants to be having sex, and maybe her husband should ask her, and maybe her no should mean no, even inside a marriage. Instead of any of that, the text frames her disengagement as a problem with her. She's being too submissive. She's not really submitting. She's defending herself. And the consequence? Not that her autonomy has been violated. Not that her husband's needs to respect her boundaries. No. The consequence is that she won't have an orgasm. Her orgasm failure is framed as the punishment for her resistance. Not her resistance is a valid response to unwanted sex. That is, and I don't use this word lightly, that is medical gaslighting. And it was in a mainstream published guide that families had in their homes. In 2026, we know better. We must know better. Consent is not a one-time event that happens at the altar. Consent is ongoing, enthusiastic, informed, and revocable at any time. Within a marriage, within a long-term relationship, within any relationship, modern healthcare providers are trained, or should be trained, to screen for intimate partner violence and sexual coercion, including within marriages and long-term partnerships. Organizations like the ACOG, the American College of Obstetricians and Gynecologists, have clear guidelines on this. Every patient encounter is an opportunity to ask, in a safe and private setting, of course, whether a patient feels safe in their relationship and whether their sexual encounters are consensual. If you are a nurse listening to this, if you are a healthcare provider of any kind, this is your responsibility. Ask the questions, create the safe space, and believe your patients. And if you are someone listening to who just heard me describe your own experience, if you are in a relationship where sex feels like something that happens to you rather than with you, where you feel like your job is to submit, where your own desire and your own no are not respected, please hear me when I say, this is not okay. That is not normal. That is not sex. And it's definitely not what sex is supposed to be. And you deserve help. The National Domestic Violence Hotline is 1-800-799-7233. Or you can text START to 88788. Please reach out. Okay, let me take a sip of my Dr. Pepper. All right, because I'm really fired up, and we haven't even gotten to the orgasm section yet. All right, part 2 of our passage, the orgasm or climax. The text starts with the climatic release of tension in both partners to the sexual act is its immediate goal. Okay, so they're framing orgasm as the immediate goal of sex. And I want to pause on this because it's actually a really common belief. Not just in 1953, but even today. A lot of people, a lot of couples, a lot of meaning the sex education programs frame orgasm as the point of sex, the goal, the finish line. And modern sex therapy actually pushes back on this pretty hard. Therapists there's extensive literature from researchers and clinicians in the field of sexual medicine who emphasize that when we make orgasm the goal of sex, we inadvertently create performance anxiety. We reduce an incredibly complex and rich human experience to a single psychological event, and we set up a pass or fail dynamic that is damaging for everyone involved. Modern approaches encourage what's sometimes called as pleasure focused rather than orgasm focused modern of sexuality. This idea is the sex is about connection, intimacy, physical pleasure in all its forms, emotional bonding, playfulness, exploration. An orgasm may or may not be a part of that experience on any given occasion, and that's okay. When you take the pleasure off the orgasm as the goal, paradoxically, people often find it easier to actually have orgasms because they're not anxious about it. So right out of the gate, this 1953 text is setting up a framework that modern sexual medicine considers problematic. Then, ideally, orgasm should take place in both the man and the woman simultaneously. Oh, the simultaneous orgasm myth. This is one of my favorites. And by favorites, I mean one of my favorite myths to absolutely demolish. The idea that the ideal sexual experience involves both partners climaxing at the exact same moment has been perpetuated by romance novels, by movies, by pornography, and yes, by medical texts like this one. And it has caused so much unnecessary anxiety and feelings of inadequacy. Here's the reality. Simultaneous orgasm is relatively uncommon. Research consistently shows that the timing of orgasm varies enormously between individuals and between encounters. A study that was published in the Journal of Sexual Medicine, and there have been multiple studies over the years, has shown that the average time to orgasm differs significantly between men and women during partnered sexual activity. For many heterosexual couples, the man reaches orgasm before the woman during penetrative intercourse. This is not a failure. This is physiology. And more importantly, sexual satisfaction, as reported by the individuals themselves. That doesn't correlate strongly with simultaneous orgasm. People report high levels of sexual satisfaction with sequential orgasms, with only one partner having an orgasm, or even with no orgasm at all in a given encounter. Satisfaction is much more closely linked to emotional intimacy, communication, feeling desired, and feeling respected than it is to perfectly synchronized climaxes. So this is ideal that the 1953 text sets up. It's setting couples up to feel like they're failing at something that was never a realistic or necessary benchmark in the first place. Now the text continues, and this is where I need you all to hold on to something. Clutch those pearls if you may. Those women who fail to react with the expected response are termed frigid. Frigid, guys. I want to talk about this word because it did enormous damage, and it echoes of it still with us today. Frigid was a clinical term used by doctors, psychiatrists, psychologists to describe who did not have orgasms, did not enjoy sex, or did not display what the male medical establishment considered an appropriate level of sexual responsiveness. It was a diagnosis. It was something wrong with you. And it was loaded with moral judgment. Frigid doesn't mean having difficulty with orgasm. It means cold, unfeeling, withholding. It implies that the woman is choosing to be unresponsive. or that something is fundamentally broken in her emotional and psychological makeup. The modern diagnostic equivalent, if and when a diagnosis is seen even appropriate, is something like female sexual interest or arousal disorder, or female orgasmic disorder, as described in the DSM-5-TR. And the diagnostic criteria for these conditions are worlds apart from the concept of frigidity. Frigidity. Modern diagnoses require that the difficulty causes clinically significant distress to the individual, that it has persisted for a minimum duration, and that it's not better explained by another condition or by relationship distress or by inadequate stimulation. And that it's not attributable to substance use or medication effects. No, that can't be it. Did you catch that? Not better explained by inadequate stimulation. Modern medicine acknowledges that if a woman isn't having an orgasm, one of the first things to assess is whether she's receiving adequate stimulation. That includes clitoral stimulation, which, and this is critically important, the majority of women require for orgasm. Hello. Research consistently shows that approximately 70 to 80% of women do not orgasm from vaginal penetration alone. Let me say that a little louder for the people who somehow still haven't heard this in 2026. The majority of women need direct or indirect clitoral stimulation to reach orgasm. This is not a disorder. This is not frigidity. This is an anatomy. The clitoris has over 10,000 nerve endings. Research published in recent years have actually suggested the number may be even higher than previously thought. It is the only human organ which sole purpose is pleasure. And for decades, for centuries, it was ignored, minimalized, or outright denied by medical science. The full internal structure of the clitoris wasn't even accurately mapped and widely published until the work of Australian urologist Dr. Helen O'Connell in the late 1990s and early 2000s. Before that, most anatomical textbooks either omitted the clitoris entirely or depicted it as a tiny external nub. That's a little disrespectful to the clitoris, I guess. The complete clitoral structure that extends internally and includes what they call the curora, the bulbs of the vestibule, and significant erectile tissue was simply left out of medical textbooks until practically the 21st century. So when this 1953 text says a woman is frigid because she can't orgasm during intercourse, what it's actually saying without realizing it is, we don't understand female anatomy. We haven't bothered to learn. And rather than examine our own ignorance, we're going to label the woman as defective. That makes me want to flip a table, honestly. Okay, let's keep going. Because the text does actually acknowledge to its minimum credit that the men bear some responsibility here. Beyond the problems of the woman, there are certain failures in the man which may interfere with sexual climax in the woman. These failures arise from an exaggerated, rapidity on the part of the man in the sexual act, and with the achievement of orgasm altogether too early for the same accomplishment to be reached by the woman. So they're talking about premature ejaculation, though they don't use that term. They call it exaggerated rapidity, which honestly sounds like a traffic violation instead. Sir, you've been cited for exaggerated rapidity in a residential zone. That's funny. But okay. They're acknowledging that if a man ejaculates too quickly, the woman may not have time to reach orgasm, which is most likely the truth. And that's not wrong either. That is the truth. Premature ejaculation is the most common male sexual dysfunction, affecting by some estimates 20 to 30% of men at some point in their lives. So this is a real thing, guys. But here's what the text does next that's so frustrating. It says, for the woman to achieve orgasm, it is necessary that the man shall be able to maintain his erection a long enough time to allow the woman to reach the point of tension which will permit her to experience orgasm. See what they did there? The woman's orgasm is entirely dependent on the man's erection. Her orgasm is a function of his performance. If he can maintain an erection long enough, she'll get there. If he can't, she won't. End of story. This completely erases the possibility of a woman reaching orgasm through any means other than prolonged penetrative intercourse. What about manual stimulation? Doesn't exist? Oral stimulation? Not mentioned? The woman stimulating herself? Absolutely not. Remember, this is 1953, and the female masturbation was considered deviant. Use of any kind of device or aid? Unthinkable. Modern sexual medicine recognizes that there are many pathways to orgasm, and penetrative intercourse is only one of them. And honestly, it's not the most reliable one for most women. Current clinical guideline encourages couples to explore a wide variety of sexual activities and to not treat penis and vagina intercourse as the only real sex. Outer course, manual stimulation, oral sex, use of vibrators and other aids, mutual masturbation, all of these are valid, healthy, normal sexual activities that can lead to orgasm and sexual satisfaction. And here's a critical modern understanding. The woman is also an active agent in her own orgasm. She can communicate what she needs. She can guide her partner. She can touch herself during sex. That's not a failure on the man's part or a sign of inadequacy. It's good sex. It's informed. It's communicative, collaborative sex. It's what we should be teaching people. Then the text drops this absolute bomb. However, it must be said also that an equal number of women, and perhaps more, are innately incapable of orgasm independent of the accomplishment of the man. Innately incapable. I want you to imagine being a woman in 1953. You've never had an orgasm with your husband. You're confused. You're frustrated. Maybe you're ashamed. You go to the bookshelf, you pull down the family medical guide, and you read what you might just be innately incapable. Born that way. Nothing to be done. It's just how you are. The damage. What we know today is that the vast majority of women are capable of orgasm. True orgasm. The complete inability to achieve orgasm under any circumstances is relatively rare. Estimates vary, but most research studies suggest that it affects somewhere around 5 to 10% of women. And even in many of those cases, there are underlying treatable causes, such as medical side effects, medication side effects. SSRIs are a big one for hormonal imbalances, neurological conditions, trauma history, or simply a lack of accurate information about their own bodies. For many, many women who believe they are incapable of orgasm, the issue was not their bodies. It was their education. It was the information they were never given. It was the permission they were never granted. Permission to explore, to ask, to prioritize their own pleasure. In the final line of our passage, it is important then to consider what the value of orgasm is and what the penalties for failure of orgasm may be to the woman's sexual life. The penalties for failure, as if orgasm is an exam she's failing, as if there should be consequences for a woman's body not performing on command. I don't even have a snarky comment for that one. It just makes me sad. So let's pivot from the heartbreak and the outrage and talk about what modern evidence-based medicine and sexual health science actually tell us, okay? Because we have come a long way. Not far enough, but a long way. All right, number 1. Communication is the foundation of good sex. Research consistently shows that couples who talk openly about their sexual needs, preferences, and boundaries report significantly higher levels of sexual satisfaction. This isn't touchy-feely advice. This is data. Studies published in journals of sex and marital therapy, in archives of sexual behavior, and elsewhere have demonstrated this over and over. Talking about sex before, during, and after leads to better sex, period. Number 2, female sexual response is diverse and complex. The old Masters and Johnson linear model of sexual response, the excitement, the plateau, the orgasm, resolution, has been significantly expanded. Dr. Rosemary Basson proposed a circular model of female sexual response that acknowledges that many women don't start from a place of spontaneous desire. Instead, they may begin from a place of sexual neutrality and move into arousal and desire through physical and emotional stimulation. This means that a woman who doesn't feel spontaneous desire is not frigid or broken. She may have what's called responsive desire, and it's completely normal. Number 3, the clitoris matters. I said it before, I'll say it again. Most women need clitoral stimulation to orgasm. This should be taught in every sex education class, discussed in every relevant clinical encounter, and known by every sexual active human being. The fact that it's 2026 and this still surprises people tells you something about how deeply entrenched this misinformation from books like this 1953 guide really was. Number 4, mental health and sexual health are deeply interconnected. Anxiety, depression, trauma history, body image issues, relationship conflicts, all of these can profoundly affect sexual function and satisfaction. Modern approaches to sexual health always consider the psychological and relational context. A woman who isn't enjoying sex isn't frigid. She might be stressed. She might be depressed. She might be on a medication that affects her libido. She might be in a relationship where she doesn't feel safe or respected. and she might have unresolved trauma. Or she might simply never have been given accurate information about her own body. The diagnosis isn't frigid. The diagnosis is, let's figure out what's actually going on and address it holistically. Number 5, consent is ongoing and essential. I touched on this earlier, but it bears repeating. Modern sexual ethics and modern medicine are aligned on this. Enthusiastic, informed, ongoing consent is the baseline for any sexual encounter, not the ceiling, not the floor. This is true in new relationships, in long-term partnerships, and in marriages. The 1953 text never once used the word consent, not once. And that absence speaks volumes. Number 6, orgasm is not the only measure of sexual satisfaction. We've talked about this, but let me put a finer point on it. Research shows that many women report high levels of sexual satisfaction, even in encounters when they don't orgasm. What predicts satisfaction? Feeling emotionally connected, feeling desired, feeling respected, experiencing physical pleasure, which doesn't have to be or end in orgasm to be pleasurable. Having fun, feeling safe. When we broaden our definition of good sex beyond orgasm, we liberate everyone, men and women, from the performance treadmill. Number 7, sexual health in healthcare. The WHO, the ACOG, the American Nurses Association, and virtually every major health organization recognizes sexual health as a vital component of overall health and well-being. It should be a part of routine health assessments. Nurses, in particular, are often the healthcare providers who spend the most time with patients and have the greatest opportunity to open the door to conversations about sexual health. If you're a nurse and you're not asking about sexual health with appropriate screening tools, in appropriate settings, with sensitivity and privacy, I want to challenge you to start. Use the PLISSIT model, the PLISSIT model. Permission, limited information, specific suggestions, intensive therapy. And as a framework, you don't have to be a sex therapist. You just have to be willing to open the door. All right. Now, in fairness, and I always want to be fair on this show, you guys know that. Let me acknowledge the things this 1953 text got at least partially right, because even a broken clock is right twice a day. 1, they acknowledged that a woman's sexual passivity was socially conditioned, not innate. For 1953, that was a meaningful observation. They called it a false assumption supported by the social attitudes of the past. They could have just reinforced the status quo, and they didn't. At least not on that point. 2, they acknowledged that women should be active participants in sex and that desire in women is natural. Again, low bar. But they cleared it, barely. 3, they recognized that a woman's total emotional disengagement during sex might be a signal that something is wrong. That she might not actually want the sexual contact. They didn't use the right language. They didn't draw the right conclusions. And they didn't protect her autonomy. But they noticed. They saw something that many of their contemporaries would have simply ignored. 4, they acknowledged that male sexual dysfunction, specifically premature ejaculation, can affect a woman's experience. They place some responsibility on the man. Not enough. Not nearly enough, but some. 5. They admitted that simultaneous orgasm is rare. That is not too frequently the case in a circumstances which I think must be admitted at the start. That's actually a refreshingly honest statement for its time. When the simultaneous orgasm was being held up as the gold standard everywhere. So there are glimmers. There are moments in this text where you can see someone trying to think beyond the limitations of their era. They just couldn't quite get there. They were still trapped in the assumptions of their time, still seeing women through a lens of function and duty rather than autonomy and wholeness. But the glimmers are there. And I think it's important to acknowledge that because it reminds us that progress doesn't happen all at once. It happens in inches. And the fact that someone in 1953 could see even a few inches further than the norm, that mattered. It set the stage for the people who would come later and see further still. So why does any of this matter? Why am I spending an episode of a nursing podcast talking about a 70-plus-year-old passage about sex? Because, my friends, this stuff is not ancient history. The attitudes in this text, they didn't evaporate in 1953. They seeped into the culture. They shaped the beliefs of the woman, especially one who raised the woman. They shaped the beliefs of the woman who raised the women who raised us. They informed medical training for decades. And their echoes are still present in our exam rooms, in our patients' beliefs about their own bodies, and sometimes, if we're honest, in our own unconscious biases. I have had patients in my career in this century, in this decade, who believe that their inability to orgasm from penetration alone meant something was wrong with them. I have had patients who didn't know what a clitoris was. I have had patients who believed that their husband's sexual needs took priority over their own comfort and safety. I have had patients who used the word frigid to describe themselves. Those beliefs didn't come from nowhere. They came from books like this, from cultures like this, from decades and centuries of being told that their bodies existed for someone else's use and that their pleasure was secondary, if it had mattered at all. And as nurses, as battle-tested nurses, it is our job, our privilege, and our sacred responsibility to push back against that. Every time we educate a patient about their autonomy, every time we ask about sexual health in a routine assessment, every time we validate a patient's experience and tell them that their pleasure matters and that their comfort matters and that their consent matters, every time we screen for intimate partner violence, every time we refer to a sex therapist or a pelvic floor physical therapist or a mental health professional, every time we hand a patient accurate, evidence-based information and say, you deserve to know this. That's how we undo 1953. That's how we undo centuries of misinformation and control. One patient, one conversation, one moment of empowerment at a time. But before I let you go, I have something exciting to tell you about. If you loved this episode, if it fired you up, if it made you think, if it made you want to learn more, then you are going to be absolutely love what's coming next week. This Tuesday, Nurse Jan is going to be joining me on the show. We're going to be diving into some incredible topics together, and I cannot wait for you to hear that conversation. So make sure you're subscribed, make sure your notifications are turned on, and mark your calendar for Tuesday because Nurse Jan and I are going to bring it. And you don't want to miss that episode. All right, my battle-tested family, let's wrap this up, okay? Here's what I want you to take away from today's episode. History matters. Understanding where medical beliefs come from helps us understand and challenge the beliefs that persist today. Women are not passive recipients of sex. They are active, autonomous, sexual beings with their own desires, their own autonomy, their own anatomy, and their own right to pleasure and safety. Orgasm is not the sole measure of sexual health or satisfaction, but every person deserves accurate information about their body and the opportunity to experience that pleasure on their own terms. Consent is non-negotiable in every relationship, every time. As nurses and healthcare providers, we have the power and the responsibility to educate, to screen, to advocate, and to empower. The legacy of texts like this 1953 guide lives in our patients' beliefs about themselves. We can be part of changing that narrative. Words matter, like frigid, submissive, innately incapable, penalties for failure. These words shaped how generations of women understood themselves. Let's choose better words. Let's choose words that heal, that empower, that liberate. Now, one final time, my disclaimers and resources, okay? This podcast is for educational and entertainment purposes only. Nothing discussed here constitutes medical advice or establishes a provider-patient relationship. Always consult with your own licensed healthcare provider for personal medical concerns. If you or someone you know is experiencing sexual coercion, intimate partner violence, or abuse of any kind, contact the National Domestic Violence Hotline at 1-800-799-7233 or text START, START, to 88788. The National Sexual Assault Hotline, or that RAINN, RAINN, call 1-800-656-4673 or chat at rain.org. Crisis Texas line, text line. I was just in Texas, guys. I'm back in Iowa today, but crisis text line, text HOME, HOME, to 741-741. If you're experiencing sexual health concerns, please reach out to your OBGYN, primary care provider, or a certified sex therapist. The American Association of Sexuality Educators, Counselors, and Therapists, or the AASECT, has a provider directory on their website where you can find a certified professional near you. You are not broken. You are not frigid. You are not innately incapable of anything. You are a whole, complete, worthy human being, and your health, all of your health, matters. All right, guys, thank you so much for spending this time with me today. Truly, this community, the Battle Tested Nursing family, is something special, and I am grateful for every single one of you. Whether you're a nurse on your commute, a student cramming between clinicals, a patient advocate, or just someone who's curious about the wild and wonderful history of medicine, you belong here, and I'm glad you're here. If this episode resonated with you, please share it. Send it to a friend. Send it to a colleague. Send it to that one person who still thinks women don't need to know about their own anatomy. Leave us a review. Drop a comment. Tag us on social media. Let's keep this conversation going because conversations like this, they change things. Maybe not all at once, but inch by inch. One real talk at a time. And don't forget, Tuesday, Nurse Jan will be here. I promise you it's going to be fire. Until next time, this is Nurse Mindy reminding you to stay curious, stay compassionate, stay evidence-based, and always stay battle-tested. Love y'all. Take care of yourselves and each other, and have a great night. Nurse Mindy's out.